Are here with Members Helping Members webinar. Thank you so much to Koriahn Quint for bringing this idea to me. I've gone through this presentation with you. We've had a couple of really great conversations, and it's really, really important stuff. And I do want to thank all of our guests who have joined us on the Zoom call. Koriahn will tell you how it goes, but essentially it's going to be, we're going to run through some slides, but as you have questions, please do shout them out. If you're watching this, you're probably watching it on the Chamber YouTube channel. In the description, we will have Koriahn's contact information, as well as some Chamber contact information. So if you have any other questions. I think Koriahn will probably open by telling you a little bit about herself, but she's a pro. She's been doing it for years. And without further ado, Koriahn, the floor is yours.
Thanks, Corey. And thank you, everyone, for taking a little bit of time out of your day to learn about this riveting topic. We actually tongue-in-cheek talked about naming it everyone's favorite topic, because I know it's not. So yes, I am Koriahn Quint. I am a certified employee benefits specialist, which is a designation that I got through the Wharton School of Pennsylvania and the International Foundation of Employee Benefits Specialists. It's basically equivalent to a college degree, but it focuses specifically on benefits. As I mentioned earlier, I'm in the benefits business since 1998, which means you know how old I am. And I am an account executive with New England Financial Services, as well as I own my own business now, benefits and beyond. And I live in Wells with my husband, Bob, my son, Bobby, and we have a pet pug, Otis. I have a grown daughter, Brianna, who lives in Sanford. So that's a little bit about me. And so just a reminder, this is for educational purposes only. I'm happy to meet with people one-on-one to make personalized recommendations, but this is kind of an overview that doesn't take anybody's specifics into account. And I don't provide tax or legal advice. So why is this topic so important? Well, it continues to get more and more expensive. So recently, the 2022 Kaiser Family Foundation report came out, which had some interesting statistics. So the average annual health insurance premiums for small firms, $7,911 per single employee. And on average, employers are paying 83% of that. So when you're thinking about hiring somebody, that's a large ticket item to be considering when you're trying to figure out, how much to pay somebody. How much can you afford when you're hiring somebody? It's not a small amount. And the average family premium has increased to $22,463. And it was interesting, I guess it's as I would expect, that small employers are paying a lesser amount of the family because it's just so, expensive. $14,376 is average. Now, even though businesses with less than 50 employees are not required to offer health plans, 53% of businesses did that had less than 50, and about 48 were only 3 to 9 people in their company. So that's kind of an interesting, it basically means people are looking to their employers to purchase benefits. Here's a little picture graph that shows the costs and how they've increased from 2001 to 2022. So I'm not going to spend too much time, but it's an interesting, picture that really shows the progression of the costs. And this slide, these all come from the Kaiser Foundation. It's a great report. I'm happy to share you the link if you're interested in looking into more about what that report says. But you can see that it's just the contribution and the cost has been going up and up and up. And it looks like the employer is still carrying the brunt of that cost. So what's this Maine, merged markets? What does this mean? Well, Maine is a small state. And so we had 2 separate markets, so the non-group and the small group. So everybody in the individual market was one pool and the small group was the other pool. So somebody went, gee, Maine's not a very big state. We should consider making that one big risk pool, because there are things that you have to do when you're maintaining a market. You have to approve things through the state. So when you have one group, you're kind of avoiding some duplication, and those are all good things. So this is really the biggest, latest change that's affecting the health insurance market. It's going to be the same rates are available for both individuals as well as groups for the same plan. So if you're a 35-year-old and you go to the individual market and you're a 35-year-old on an age-based group plan, they're going to be the same rates for the same products. However, with a group, you can do composite rates, which is basically the average age of your group. Starting January 1, the Clear Choice standardized plans are going to be rolling out. These Clear Choice plans were already rolled out to the individual market earlier this year, but now there's going to be a set of standardized options. And they tell us that these plans are going to be virtually identical. We're finding little bits of differences here and there, things like value adds and the add-on type of benefits that are differing, but they're supposed to all be very, very standardized so that when you're looking at one company with one plan design, you go to another carrier with the same plan design, you're basically looking at the same thing, which makes it a little bit easier to compare. So what that means is that most plans are not going to renew as is. There's going to be a new option that you're going to be mapped over, and most plans are going to have some differences. So what is this really going to do for us? Well, when we ran the numbers to combine everything, the individuals are getting on average across all plans and all carriers an increase of 13 to 14%. However, on the other hand, we're seeing in the small group market, we are seeing decreases. So all of our December renewals, we're basically reviewing and seeing who's going to benefit from making a change. And basically, we're proactively reaching out to our clients saying you might want to consider making a change because of the rate relief. And as soon as we get through that, we're going to go back and to the prior renewals, because it really, there's a lot of groups that will benefit from doing an off-cycle change, which is something you can do once in a 12-month period. So if you have a renewal that's April or June or anything that's other than January, might be a good idea just to get numbers, just to compare and see if it's going to benefit you. So I'm thinking about how to guide people. You know, what avenues do they have to purchase insurance? Well, you can always go direct to a carrier, and you can use a broker. And then there's a couple of other options that I don't see a lot of, but I felt that it was worth mentioning: professional employer organizations and association health plans or trusts. So direct from a carrier, you're limited to what they have. You know, their product knowledge is usually most focused around their own products. They might have some awareness of what else is in the market, but they're really experts in their own products and their own carrier. Or you can use a broker, and this is a little bit of a shameless plug for the broker community. What we do is we shop your options. Part of what we need to know what's out there to help guide people in the best direction. It doesn't cost anything to work with a broker. There's an amount of your premium that's already allocated to any commissions. And if you go direct to the carrier, they just retain that to pay their salespeople. So there's no extra cost when you work through a broker. All brokers have access to the same plans and the same rates. In the under 50 market, there's no negotiation. It's not like you can ask them to review claims experience and offer a better rate. It just doesn't exist. They're all lists of rates that are filed with the state, and they're based upon age. So there's not a lot that differs. So when you're looking at a broker relationship, you want to do, you know, who do you get the best service from? You have the best relationship, and who do you trust the most? Also, not all benefits brokers do full benefits administration. So that would be something, if you're comparing brokers, ask if they do that. We happen to offer full benefits administration. And your broker relationship is something that can be changed at any time with just a letter. So if there's something going on that you're not happy about, or if you just want a better relationship, know that you're not stuck with your broker. You can move that at any time, and it's just a letter requesting that. So as long as the new broker is appointed with the carrier that you're working with, no issues. All right, professional employer organizations, I have had a little bit of exposure, but there's really not a lot of options. People are looking at different and creative ways to address this. These professional employer organizations is basically like outsourcing your staff. And so you're sharing the responsibility with this entity, and that entity retains some control over those employees. So when you work with a professional employer organization, just be aware that there is a little bit of loss of control. And also be careful. I have come across several of these PEOs that are not offering all of the compliance training and are not necessarily doing all the HR duties that should be done in that environment. So if you are considering working with a PEO, make sure you just check on those things to make sure that they're being taken care of. Don't assume. They're definitely not automatically. I would make them verify. And then last but not least, association health plans. I worked with the Maine Credit Union League Insurance Trust to get that set up. That was 18 months of my time there, which was a huge undertaking, and very proud to have that available. So the people in the credit union world now have something that they can work with that gives them a little bit of control over their costs. I'll get into how that program works in a little bit. But there are not a ton of these around. You know, they're like the Maine Bar Association went belly up, or I should say their insurance program blew up. It didn't work well because they didn't contain costs. There are a handful of them around. I even reached out to the restaurants association. They had a plan, but it's not available in our state. And, you know, so it's like they're limited, but they're out there if you happen to be in an industry that has one. And you get a broker relationship with both of those options as well. Some of them are open, where you can name any broker as long as they're appointed to work with a carrier. And some of them, the broker's already established, and that's who helps set up the plan. So who do we have in the state? Who can we go to? Well, there's your Anthem, your Aetna, Community Health Options, Harvard Pilgrim, United Healthcare, and a new insurance company that is coming to Cumberland County only. I'll spend a little bit more time on this a little later in the presentation, but Taro Health is new to Cumberland County only, January 1. I'll wait and go into that a little more detail. So looking at traditional group insurance, what are the pros and what are the cons? Well, the pros are that it's becoming more and more necessary to have a health plan to be able to attract and retain quality employees. It is a tax-deductible business expense when you're paying for insurance. That is definitely something I would encourage you to use as a deduction. And if you have younger employees, then composite rates can be very beneficial to you. Now, cons, well, it's still expensive. The costs keep rising. There are participation requirements. So outside people covered elsewhere, the remaining people, 75% of the people have to sign up. So you're only allowed so many people that are uninsured. And if you can't meet participation requirements, you can't have a group health plan. So that's been a sticking point for some groups, that it's like if people are just against insurance for any reason, you're not going to be able to meet that compliance requirement. So that's one of the negatives. The employer typically picks the plan. They have to be able to determine what plan is going to work for the majority of their employees. And that's often a difficult thing to choose. Sometimes you can have choices, but it's typically limited to 1 to 3 choices within a group. And if you've got older employees, because it's based upon average age, that can be a negative as well as a positive. So I put it on both sides. So we go, okay, well, what else? We got individual. So in the individual market, we've got pretty much the same carriers, except Aetna does not participate in the individual market and United does not participate in the individual market. Now, it's important to understand these are the only carriers that have comprehensive major medical plans approved for sale by the state of Maine. And so if you're looking at individual insurance and you're talking to a carrier that is not, oops, I don't know what's going on there. Sorry, my screen just blipped to a different place. So if you're looking at an individual health insurance program and they're not on this list, it's not an ACA compliant medical insurance plan. So just to be cautious, know what you're buying. So the pros and the cons of individual plans. Well, one of the biggest pros is the fact that there's federal funding available in the forms of advanced premium tax credits and subsidies. And that makes it awfully difficult when you're trying to compete with the individual market. You know, you're competing with the federal government for funding. One of the benefits is that you don't have to pick a plan, and the rates are based upon age. So younger employees, you know, young people are going to benefit from lower rates. Same thing on the other side is that older employees, because of the fact that they're based on age and the rates go up as you are older, this can be a negative. Now, it's still expensive, especially without subsidies and advanced premium tax credit. So let me talk for a quick second, because I've noticed a lot of people are misunderstanding how this works. So if you have access to affordable employer-sponsored coverage, you are not eligible for subsidies and advanced premium tax credits. So people not understanding what the question is asking, where they're like, yeah, my employer offers it, but I think it's too expensive. Well, is it too expensive based upon the government's regulations? That's where it's just another option to get care, but that funding is pretty key. So if you have access to the funding, it can be very affordable. So what else can you do? Well, you can combine funding arrangements with the different health plans. So a popular strategy has been health savings accounts, but it has to be paired with a high deductible health plan, and everything goes towards the deductible. So that doesn't necessarily work with everybody. I find that health savings account compatible plans work with people that either have low expenses or predictable expenses. Those are people that tend to be happiest in that structure. Health reimbursement arrangements, that can be added to a group health plan. Those are employer funding. Basically says we're going to help you meet your costs. So maybe we'll help you with your deductible, or we're going to make it so it feels like your deductible is smaller. Flexible spending accounts, that allows employees to use their own money to be able to pay for future medical expenses, but you have to pick your dollar amount at the beginning of the year, and if you misestimate at the end of the year and you have extra money, that gets forfeited. So things to be aware of. So within the last few years, they came out with a couple of different interesting structures. The QSEHRA, which is a Qualified Small Employer Health Reimbursement Arrangement. That one had a lot of attention at first, but then it kind of fizzled out. There weren't that many groups that jumped onto it. The next iteration of it was the Individual Coverage Health Reimbursement Arrangement, or ICHRA, as it's referred to. And the ICHRAs are actually really interesting. I apologize, I'm going to put you through this lovely slide. But this is basically a really brief comparison between ICHRAs and QSEHRAs. So the QSEHRA came out first, the ICHRA was next. QSEHRA only works with companies that are less than 50 employees. So it will not work for if you are subject to the employer mandate. So if you've got 50 or more employees and required to offer coverage, the QSEHRA is not going to do it for you. However, an ICHRA can be used with any size business. And you can offer group insurance along with the ICHRA as long as you offer it to different classes. And there are a limited amount of classes that you can use to differentiate. So the things that you can differentiate are typically full-time, part-time, salaried, hourly, and seasonal. So you can see how that might limit how you can separate people into different different groups, but it is possible. QSEHRA, all full-time eligible can be offered to part-time, but you have to have the same allowances to full-time and part-time. So it's kind of the part-time people get a little bit of a better deal when you offer it to them. There is a cap in terms of how much people can use towards the payment of the payments towards employees. So the following caps: $5,250 per year for a single, which ends up being $435.15 a month, and for families, the cap is $883.33. So it's limited in terms of how much you can help people. Some people that might be enough, other groups that may not. These are month to month. There's no rollover for funds. It's just simply, the money is there being made available from the employer. Budgetary guidelines. So you can offer allowances by class or family status within the ICHRA, but only family status within the QSEHRA. So QSEHRA, companies looking to reimburse premiums and expenses, but they want to offer the same allowance to all full-time employees, have a variety of different situations in less than 50 employees. But the ICHRA will work with companies that are looking to reimburse premium only. If you want to vary your allowance by class, we typically, I've seen it by age, if you're doing age-based, because you're allowing them to use the individual market to get coverage. So you don't have to pick what plan they choose, you just give them a budget, say, this is what I'm willing to offer. If the advanced premium tax credits are greater than what you have available from the employer contribution, the employee can forego the employer contribution, which benefits you, and take the federal funding, which benefits them. So it's like whichever one is better, they can choose. And if you don't have to pay because the government's paying, then you don't have to pay. So it ends up working out really well. And we're seeing a popularity in these groups that are large groups. We've recently worked with a couple of employers that have over 50 employees, and they're using that just to satisfy their requirements. And as long as it's being, if it's considered affordable and offered to at least 95% of the employees, that's considered meeting your requirements for the applicable large employer. Okay, that slide is so overwhelming, so I'm going to move on. So, okay, we've talked about group, we've talked about individual, we've talked about funding arrangements, but what else is there? How else can we meet the healthcare needs? Well, there's a couple different strategies that I'm going to go over, and you may or may not have heard of them. So one of them is direct primary care. So these are arrangements where doctors' offices have kind of said, we're not going to do the rat race anymore. We want to spend more than 5 minutes with our patients. They've all kind of created these little groups, and you pay a membership fee to be part of it, but then you don't pay anything when you go and you get care. So it's a very different model than what a lot of people have been doing. So pros, this is an affordable option. It promotes strong patient-doctor relationships. These physicians are very accessible. You can even text them and email them off hours. So they're really a unique model of meeting care. And the fact that you don't pay when you actually get care is huge. So it's like you have zero copay, but you're paying a monthly membership fee. So the negatives, this type of a program only addresses the primary care needs. So what if you need surgery? You need to have some coverage for that. There's no hospitalization coverage. It only really addressed the primary care need. And the monthly membership fee, they could range, $100+ a month per employee. And it doesn't, or I should say, hadn't worked with traditional insurance until now. And that's where I want to introduce Taro Healthcare. So Taro Health has basically recognized the value of these direct primary care offices, and they found a way to make it work with insurance. So they're launching just in Cumberland County. So where, Brunswick and Topsom are part of Cumberland County. So I wanted to make sure that I talked with you guys about that.
Koriahn, Topsom is in Saginaw, but Harpswell, and yeah, Brunswick and Harpswell.
Thank you. That's what I was thinking. I know I checked and there was so I figured it was really important for you guys to know if you live or work in Cumberland County, these plans will be available to you. And they're starting with Cumberland County because they want to show proof of concept. They want to make sure that people understand how these plans work and that they can work. And there's also a high concentration of direct primary care providers in Cumberland County, and they're actively recruiting to bring more people to Maine. Maine just has the right set of circumstances to launch this program. So this is just a quick image to talk about the differences between traditional and a program like Taro. So typically a traditional primary care visit would cost between $75 and $150. So if you had a high deductible health plan, that's basically what you'd be paying each time you go and see your primary care doctor. And you're lucky if you get 5 to 10 minutes with the doctor when you need to get an appointment. And these are statistics that they came up with that it could be 2 weeks before you can actually get in to meet with your doctor. And they usually carry a lot of patients. The traditional primary care doctor is kind of it's like a hamster wheel. They're volume driven, where Taro meets the needs differently. Because they're paying a membership fee, they're not out there trying to meet their quota. They're basically their basic needs are taken care of. They're not looking to nickel and dime people. They're already getting paid. So when you go for a visit, there's no charge at the time of the visit for that visit. The average time spent with their patients is 45 minutes. They tote that they can get you in usually in 24 hours. They carry smaller patient loads. 500 patients is about their average. They do inpatient, and they allow you to call or text your doctor outside business hours. So it's pretty cool. It's a very different way of working, and these programs will never be HSA compatible because they're directly opposite to the regulations. So health savings accounts say that you have to have everything subject to your deductible. This offers first dollar coverage. So they're never going to be able to be compatible unless they rewrite the law. But it's a very pleasant experience for people. And so the way that these offices are saying, okay, we understand not everybody's going to want to work with a direct primary care provider. We get that. So they've basically come up with 2 versions of each of their plans. They've got a gold, silver, and a bronze. And they're using clear choice plans for people that don't want to participate with a direct primary care. Either they don't have one or they don't want one, or maybe they've got a really strong relationship with their current physician and we don't want to take that away. So you can offer 2 side-by-side bronze options, one using direct primary care and one using the clear choice model, which allows you to go to anybody that participates within Tara's network. And Tara has partnered with Maine Health. So they said every Maine Health facility is going to be considered a network. And again, we're really trying to come up with ways to look at things different. So this is very exciting to see something innovative and new coming to Maine. So next, or I should pause and say, does anybody have any questions about Taro? Feel free to interrupt me at any point if you guys end up having a question.
I think you touched on it briefly, but I wasn't quite sure. What were you seeing for membership costs per month, per family, per individual?
Well, outside of Taro, so let's just say you just wanted to go to primary care, they're
Yeah.
usually, I've been seeing $100 a month, somewhere in that range. But when you go with Taro pays your membership fee.
Yeah.
So you don't have to, it's not like you have an added cost. They will pay for that membership fee to be part of the program. So it's really neat.
Thanks, Chuck.
Yes, thank you, Chuck. I appreciate that. And feel free again to interrupt me at any point. Something else we're seeing popularity.
Corey, just so in case people on the recording can't see the chat, Chuck did put in the chat that he pays $50 a month for direct primary care. There we go.
Thank you. Yes, they do vary. You know, I'm saying average 100 because I know there's some that are over and some that are under. But it's just such a unique model. Okay, so switching gears, another way to meet the healthcare need is not through insurance. I know this is really different to say to people. And again, in the under 50 market where you're not required to offer health insurance, this is something that could work for some groups. Health sharing programs basically are a group of people that have bonded together to feel like they can manage those healthcare dollars better than traditional insurance. So it's great for a couple of reasons. It's affordable. They're not limited to the Affordable Care Act, which can be a pro and a con because the Affordable Care Act makes them pay for things, but that drives up the cost. The more things you require an insurance company to pay, the higher the premium is going to be. These programs typically group things into needs. So similarly, how they do global billing for baby delivery, they've basically taken that everything as a need. So I'll use the example of knee surgery. So you typically have some, tests to determine what's going on. They might say, let's try physical therapy. And then, okay, physical therapy is not working. Let's do an MRI. Oh, yep, you need surgery. And then after surgery, there's physical therapy. All of those things are grouped together into one need. And so the companies that I've worked with typically limit the number of needs per year. And there's something called an initial unshareable amount, which is basically the deductible, but we cannot call it that because it is not insurance. So I've seen companies that pair it with an employee assistance program that covers preventive care. So it looks and feels more like traditional insurance. But again, it is not insurance. One of the big negatives for programs like this is that they don't cover pre-existing conditions. So at least not initially. The companies that I've had the most exposure to have like the first year they cover pre-existing conditions, they cover nothing towards pre-existing conditions. The next year they might limit it to a certain dollar amount, and then the next year it goes up. And so it could be 4 years before your pre-existing conditions are covered in full. Typically with these health sharing programs, you either need to sign a statement of faith or a commitment to health, depending on the type of program that you're going with. And again, it's not subject to the Affordable Care Act, so you can't assume that everything is going to be covered the way that it was covered before. In fact, you can't even use the word covered. Everything will be a benefit like everything was before. So there's a certain amount of trust with these programs. You have to trust that the program is going to work the way that they say it's going to work, because it's not a legal obligation. It's not a contract that they're required to fulfill. So it can meet some people. We've done groups where we offer the health sharing plan, and for the people that it doesn't work, we help them obtain individual insurance, which is, again, a really unique way to meet people's needs. But there's pros and cons to everything. And that's kind of what I wanted to add for your information. So, all right, oops. Okay, so limited benefit plans are supplements. So some of the things that I've been having people come to me and they've explained, when somebody comes to me, I'm always like, what did you have? What did you like? What did you not like? And I research to know what's out there, because some people might benefit from certain programs and other people would not. So the whole point of this presentation is to make you aware of what's out there and tell you the things to be cautious about. So limited benefit plans essentially are supplements. So yes, they're affordable because they cover specific risks. They're not limited by the Affordable Care Act because they only cover specific risks. And they only insure specific things, like it could be an accident plan, a hospitalization plan, and maybe a plan that covers doctor's visits. But that will be all that it covers. It's not comprehensive coverage, again, not subject to the Affordable Care Act. And it definitely can leave members exposed to additional risks. I would not, from an employer's perspective, I would not go down this road as an employer, because so many people misunderstand what they have, and it has a potential to leave members exposed to additional risks, which if you offer it as an employer, there's a potential liability there. So I caution you, that's not usually a good fit for a group. But I have seen plenty of people that come to me, they thought they understood what they had, and then they had a claim and they realized that there were a lot of things that weren't covered, and they've got huge bills. So, but I've seen them, and it's important to know that they exist. All right, minimum essential coverage, often referred to as MEC plans. You may have come across that in your dealings. These are, again, affordable. I was really struggling with what to put as a pro for these plans. They do ensure the 10 essential health benefits, and it's better than going without coverage. So these minimum essential plans are not comprehensive coverage. They're not about providing coverage. It's about meeting the requirements of the law. That's all they're trying to do, is they're designing the plan to satisfy the requirements of the Affordable Care Act. And there's a lot of potential for having uncovered risks because of the fact that it is bare bones coverage, minimum essential coverage. Next strategy is one that I'm really surprised. I talk to people and they're like, oh, I didn't know you could do that. So I want to make sure everybody knows that this is an option. There's something out there called level funding or stop loss insurance. And these programs are really great because you have the potential of getting money back if you have better than anticipated claims. Now, the premiums, what ends up happening is you get a premium that is closer to what your members are actually using. There's a lot of plan design flexibility. You can usually choose from a variety of different deductibles and copays, and you can do a lot more tweaking than you can in the traditional market, because the traditional market are pretty much cookie cutter plan designs. So the level funded stop loss, it's kind of cool that they give you that flexibility to be able to do things differently. And if you have a healthy group, these programs are medically underwritten, so it can be a pro. Now, something to be aware of, the state requires that you have a minimum of 11 enrolled. So this won't work for every group. You have to be a bigger size group for this to work. Now, they typically have a run out period, which basically means that they leave the books open so that if any provider was late in submitting the claim, they're still going to get paid. And those run out periods could be 9 months, could be a year. Usually that's what I'm seeing. But after that period of time, if you get less than anticipated claims, you get money back. I've got a visual to share on the next page. PCORI, the Patient-Centered Outcomes and Research Institute fees, we thought they were going to go away and then they brought them back. And so plans like this are subject to those. And there are a few other little compliance things that you'll need to do some notices and stuff. And if you don't have a healthy group, or I should say, if your group is not better than the average health, then it's not, the numbers aren't going to make sense. But it's an easy way to tell if you're better off in the traditional market, or if you're better off being level funded. We do something we call a free risk assessment. It's basically have everybody complete the questions, submit it to an underwriter, have them come up with a rate. And if it's less or equal to what you're currently paying, you get the advantage of having money back in better than anticipated claims years. So right now, when you pay a premium, there's a certain amount that's allocated towards the actual cost of insurance. There's an amount that's given towards administrative expenses. So that's basically paying people to process claims, paying people to push the paper, make those transactions. And then a portion has to go into paying claims. Now, in the small group market, there's a requirement that no more than 20% of the premium can go towards administrative expenses. So they're very limited with what they can do. This allows you basically to see the different components, and that claims, the amount that goes into the claims fund. This is kind of, I like visuals. I don't know if you guys like visuals, but money that's not spent on claims is returned to the business. So your premium dollars go in the claims pre-fund. As people have their claims, then the money pays out. If there's any money left in the account at the end of the year, that gets either returned to the group or a lower premium payment. And I have had a couple of really great successes with this program. I have a company in Westbrook that has, I think they're about 17 employees, and they're getting a $30,000 refund check because they had better than anticipated claims experience. So that's just one success story about how these can work. So any questions before we move on to our legislative updates?
Wow, that was a lot of information, Koriahn.
I know.
No, and it's great, and that's why it's so great that we have this recorded too, so people can go back. But yeah, any questions on any of those products that we have right now? All right, let's tackle legislative, and I bet we'll have some questions afterwards.
All right.
So.
I try to go through this pretty fast because it tends to be a little bit boring, but we'll get through it. Okay, so first I want to start with a couple of bills that did not pass. And it just kind of tells you what people are interested in doing and what the conversation is. So an act to expand adult health care insurance, which was Representative Brooks in Lewiston. So pediatric dental is a requirement for the Affordable Care Act plans. And so basically people are saying, well, why is it limited to just kids? Why can't we offer it to adults? Well, they vetoed it. That did not pass, but the thought was they wanted to see if we could expand that to adults as well. There are plenty of other dental access that you can get for adults, either in the individual or the group market. LD 1463 is an act to make healthcare coverage more affordable for working families and small businesses. This just cracks me up. This bill would reestablish the federal health insurance tax at the state level, and it would impose an assessment of 2.85% of the net written premium on health carriers to fund the Maine Healthcare Affordability Fund. So just listening to it, and they also had intended for that money to address the family glitch, which is when they were thinking about affordability, they did not take into account that employers don't necessarily pay for family, or they certainly don't usually pay as much for family as they do for an individual. So when they're doing the affordability rules for the individual market, they only based it on the single. So the family glitch is basically talking about the fact that it can be astronomically expensive for a family, but affordable for an individual. And this did not end up passing. I find it entertaining because it's like, we're going to charge a fee to lower your costs. Nothing is free. Somebody's always end up paying for it. All right, so those two did not pass. Now we're going on to those that did. So 1266, LD 1266, an act to require dental plan medical loss ratio reporting and review. So basically, there's medical loss ratio is the amount of money that's spent on claims versus administrative, so that they have to keep track of how much they're spending and how much they're paying in claims versus how much they're taking in premiums. Some of you might receive, there were some refund checks that went out to Anthem clients because they audited and found that they had charged too much. They had to issue refunds. So I was a little concerned about this because dental in general tends to be, they end up with low loss ratios. So I called Delta Dental, our biggest carrier in the state, and I said, what does this mean for you? And they said, oh, we're already doing it. Nothing's really changing. So it's one of those hullabaloo about nothing kind of things. Next, LD 1331, an act to make individual and small group health insurance more affordable in certain high premium counties. So this was put forth by a representative in a rustic county. So what we've seen is that across the different areas of the state, it's just more expensive up north. So what they did is they kind of tweaked the measurement, the difference that they can charge from the least expensive part of the state to the most expensive part of the state. So it kind of gives a little bit of premium relief for that area. So it's kind of like the higher populated areas are kind of helping a little bit to subsidize the northern part of the area. But they were so much more expensive than everybody else. I think it needed to happen to make it work better. All right, on to pharmacy prescription drugs. So LD 1776 is an act to allow pharmacists to dispense an emergency supply of chronic maintenance medications. So have you ever entered a situation where maybe you've changed carriers and you don't have your card yet, but you need to go pick up your prescription, or maybe your prior authorization is pending and you can't get your prescription until that goes through? Well, people that are on chronic medications, or chronic maintenance medications, they really need to stay on them. Otherwise, bad things can happen. So what they're doing is they're giving the pharmacist the discretion in certain emergencies to give a temporary supply. It is at their discretion, and they limit it to twice in a 12-month period. So you can only get in that situation once every 6 months, but it allows a little bit more flexibility. So I think that's a good one. Also, an act to require health insurance carriers and pharmacy benefit managers to appropriately account for cost sharing amounts paid on behalf of the insured. So the pharmacy is such a confusing area of the insurance because of the way that they do things. So a lot of these pharmacy manufacturers will give rebates or discounts when you reach certain volumes. They kind of encourage doctors to promote their drugs. And so when they're applying how much you're getting, it does get confusing, like who's paying for it, which entity, was the payer. So this just basically makes it really, really, I don't have the words today. How do I say that? It's basically just requiring them to show the amounts, whether it's paid by another entity or paid by yourself. So like if a rebate comes in and it lowers your costs, that has to be reflected in how everything works. It's taking something very confusing and making it slightly less confusing is the goal, but we'll see how well that works out. Yeah, it's
You're doing fine. You're doing fine. No, it's the Tuesday after a holiday weekend. No, that's all.
So, all right, the next one is an act to improve children's mental health by requiring insurance coverage for certain mental health treatment. This was submitted by Rep. Tepler from Thompson. So the bill provides that health insurance carriers may not deny treatment for mental health services used evidence-based practices that are determined to be medically necessary healthcare for an individual's 21 years of age or younger. Evidence-based practices have to be defined, and clinically sound and scientific-based policies and practices. This was put through kind of on an emergency basis, so I have a feeling that there was a child that needed mental health services and they were denied. So they basically, this was put through on an emergency basis. This is, insurance companies cannot deny mental health as long as it has evidence-based practices, and they're going through what works through the clearinghouse and the Title-E Preventive Services Clearinghouse. The legislation also makes technical changes to the state law requiring related mental health parity to be consistent with federal law and regulations. Always makes me chuckle when you have to, a law says it has to be consistent with another law. Should be, I would think that would be a given, but so that's good. Mental health is really important, and making it accessible is even more important. Okay, so mandated benefits for coverage. This is a 2023 new regulation, an act to clarify health insurance coverage for postpartum care. So as enacted, this bill requires that maternity benefits provided by health insurers include coverage for 12 months of postpartum benefits, postpartum care that meets the recommendations of the American College of Obstetricians, Obstetrics, and Gynecologists. And this is going to be applicable to policies issued or renewed on or after January 1 of 2023. All right, so this is another one that I'm surprised it took a while for this to go through, but LD 1798 is an act to ensure health insurance coverage for certain adults with disabilities. So basically, if somebody is a dependent, even though they're an adult, the way things are working, they're still an independent. They're not considered, switching the other way around. As of today, if they were fully dependent, just because they were over the age limit, they would need to be considered their own entity. This bill is amending it so that if they're an adult who is unable to sustain themselves through employment in the same manner that a dependent child on a parent's policy, the amendment clarifies that an insurer is required to offer coverage to a dependent child with a disability at the option of the policyholder, regardless of age. So I think that makes sense. And they define the definition of disability to include mental disabilities. So I think that makes a lot more sense. If you've got a dependent child, regardless of their age, they can still be your dependent as long as they're disabled. So that's a good one. And then we've got an act to improve access to behavioral health services by limiting cost sharing by insurers. So this one is basically the first office visit of the year, first primary care visit, and the first mental health visit of the year, as long as it's not an HSA plan, needs to be covered in full. So there's zero copay for the first primary care visit and the first mental health visit of the year. And those deductibles, the copays must apply towards the deductible. And this is a requirement that applies to both individuals and group plans issued on or renewing after January 1st. And it does establish a similar requirement for large group plans. We echo the amount, and this is going to begin on January 1st. All right, something that a lot of people are pretty excited about, beginning in 2024. So this is not going to happen this year. This is going to be another year away, but fertility care is going to be a covered benefit in Maine. So that's a really, typically you would have to enroll in a plan that participated in the Massachusetts network in order to get fertility coverage today. There was definitely a need for offering those. So people will be very excited to be able to have access to this. Keep in mind, the more requirements that we add to an insurer, the higher the costs end up being. So that's the negative of the plan, but I'm hoping that maybe populating our state more will end up benefiting us in a different way. All righty. Mandated benefits, again, these are starting in 2024. LD 665 is an act to promote better dental care for cancer survivors. Well, it makes sense that if somebody has gone through cancer treatment, they have a greater need for tooth care because you have a higher chance of getting infections and tooth loss and decay. So this is an enrollee prior to beginning cancer treatment, or that are what's happening to your mouth are either directly or indirectly the results of the cancer treatment, requires that they'll cover they will cover those services because you're a cancer patient. Next one is an act to approve outcomes for persons with limb loss. So LD 1003. There's already a provision that allows for one prosthetic device, but this is now allowing the requirement of a prosthetic device for the purposes of recreation. So allowing somebody to get out and be physical. And for enrollees under the age of 18, this is in addition to the requirements to cover the prosthetic device to meet unreleased medical needs. So this is going to apply to plans issued or renewed on or after January 1st of 2024. And the amendment also requires insurers to report to the Bureau of Insurance their claims experience by providing the coverage services after 4 years. I really appreciate that they're adding that in there, because it's basically they're making sure that this provision is actually working for people, that by measuring the success of the program will determine if that provision is necessary to keep within the law. So I know that the legislative updates is typically one of the hardest. I am not an attorney. I don't speak legalese. I've had to really do a lot of research to understand what these benefits are really doing, but hopefully I've paraphrased it in a way that makes sense. And if you're interested in more information, feel free to contact me. I appreciate your time today. There's my contact information, and that the Kaiser Family Foundation is a really interesting report, talks about the statistics of deductibles and the relationship over time and who's getting covered, who's offering coverage. They talk about different business sizes. So it's chock full of information I'm happy to share. If there's any questions or anything that I can be of assistance, please let me know.
Wow, Koriahn, that was incredible. I was on my phone. I was looking at some of the terms and the LD numbers, and such a comprehensive look at things. And for someone who admittedly I should know more about this than I do, this is my second or third time seeing this presentation, and I keep picking up new bits. And I noticed there were some new things in there too. So thank you for all of that. With that, the floor is now wide open for questions of what was covered, other things that have been tickling your brain. Let's try to keep it to insurance, but whatever you've got that you want to ask about, now is the time.
Got it.
Andrew.
Hey, Koriahn, can I just ask a quick question about tarot?
Andrew, we can't hear you again in some weird.
I
Can you hear me now?
Yes.
All right, there must be a delay in getting up to me.
Yeah.
So no, thank you so much. So tarot. So our nonprofit is unusual in, like, our physical legal headquarters are in Portland, but our mailing address is in York County. So how does something like is that even something to consider or look at, or is that not?
Well, I would look at the fact that your providers would need to be in Cumberland County, because that's where they're located. So if you're okay with that and you've got the physical address in Cumberland County, they don't care where the mailing address is.
Okay.
So
right.
Yeah, just know that they're because they're launching in Cumberland County. I think they're adding other, well, I know that they're adding provider practices all the time. They're talking with, if they find out about a direct primary care practice that they're not working with, they go and they visit and try to get them to participate. So I would say it could work as long as the circumstances are right, that there's a provider that you want to see that's within the area.
Okay, no, that's super helpful, and I really appreciate that. So thank you. Nice job as always.
Thank you. Yes, and Andrew's one of my partners. I use Andrew's material when I teach a lot of the classes that I teach. So I appreciate Andrew, you being here in multiple hats.
Other questions, other comments, other pieces that interest you?
And I always welcome feedback. So if there's something I could do to make it better, let me know.
Jess?
Yeah, I've got a question. If we were to use the ICHRA, does that have the minimum participation of the 75% of eligible employees?
No. That's one of the benefits of ICHRA, especially, you know, in a small company. They're much easier to administer in a small company because there's a lot of moving parts and each member may have a different health plan. So, you know, the more members you have, I think in a company your size, an ICHRA can work really, really well.
Great, thanks.
Yeah, no problem. And I'm happy to meet offline if you wanted to continue discussions.
That's it. Yeah, yeah. And other questions, comments like that? All right. Well, I think at some point here during the next legislative session or after the next legislative session, Koriahn, we might invite you back for some of those legislative updates that are so important. The cloture date for submitting bills is still a week or two away, so we don't know everything that's going to be presented. But that look forward that you did, I was looking up some of those because those are particularly important topics for us just to keep an eye on, because our chamber is going to be taking some additional I think steps supporting the bills that need supporting and that sort of thing. So nothing but compliments here in the chat, by the way, for those that can't read the chat. A lot of people with their thank yous. So thank you to our attendees. If you attendees, why don't you stay? I'm going to start the recording in just a second. Koriahn, thank you so much again for doing this for us.
Thank you for having me.
All right.